This UCSD TV program is presented by University of California Television. Like what you learn? Visit our website or follow us on Facebook and Twitter to keep up with the latest programs.
I'm Mike Kalichman. I'm the Director for the Center for Ethics in Science and Technology, and I want to welcome you to another program in our Exploring Ethics series. Especially for those of you who are new, the purpose of our series is to give the public a chance to be part of a conversation about new developments in science and technology, to think about where some of the ethical challenges are, where are the hurdles that we need to face, and help the scientists to think about what would be the ways we might overcome those hurdles and those challenges. The person who's going to be serving as moderator tonight is Camille Nebaker. I have worked with Camille for about a decade now, or maybe even a little more. She formerly was at San Diego State University. She's now at UC San Diego, and has a long-standing interest generally in research ethics. But over the last couple of years, the focus of tonight has become a major area of interest for her, and we're going to be bringing into this series people that she knows of and has been working with, and I've asked her if she could be the moderator for the first program in that series. So Camille is an assistant professor of family medicine and public health at UCSD, and a colleague and friend, and I want to welcome her to moderate this evening's program.
Hi, good evening, everybody. My name is Camille Nebaker, and it's my pleasure tonight to introduce to you Dr. Kevin Patrick. Kevin is the first speaker in the series that Mike mentioned on digital health, and we don't have a name for that series yet, but it's going to be around a theme of using technologies to promote health and or track health behaviors. So Kevin's a professor of family medicine and public health at UC San Diego, and he's the director of the Center for Wireless and Population Health Systems at Qualcomm Institute, Cal IT2. He has an impressive history and credentials that are in your program, so I'm not going to go through and list all of those, but really amazing history. And I met Kevin about 20 years ago when I was working at San Diego State University, and I was hired there to basically create and oversee their human research protection program. And Kevin at that time was the director of student health services and had started to launch a program in clinical trials at a university that had no medical school, which was fascinating in and of itself. But one of the studies that really caught my attention and got me interested in Kevin's work was that he was starting to engage pharmaceutical companies in student health, and one of the studies had to do with an experimental condom. And as the director of the institutional review board that had oversight of human research protections, our students would then become human subjects testing an experimental condom, and I could just envision the headlines, which I really didn't want to do. So it got me to start paying much more attention to Kevin, and he went on to do some really incredible work, getting funding from the National Cancer Institute, National Institute of Health, the CDC, and most of his work focused on health promotion. He went on to move out of college student health, but never leaving it, actually basically creating a discipline in the study of college health. But went on to do work with the PACE project, and during my time at San Diego State, Kevin left in 2003 and went to UC San Diego. And fast forward about 20 years, as Mike said, we're both there now. We're both in family medicine and public health. And I have gotten very interested in the ethics around emerging technologies that are used in research, because as a person that's on a human research protection board, I see the disconnect between the people that are using these technologies to advance science and the research review, or institutional review boards that are charged with protecting human subjects. So I'm just really fascinated by the work that Kevin's doing with the center, and he is now directing a new initiative that's called the Health data exploration project, which is supported by the Robert Wood Johnson Foundation. And the HDE brings together stakeholders to find ways to optimize the personal health data that's captured by wearable devices. How many of you are carrying a smartphone tonight? And how many of you are wearing a wearable device? So these are the kind of things that Kevin's going to be talking about tonight, what kind of data is captured, how that data can be utilized for not only personal health, but for public health. And with that, I'm going to, Kevin, let you take the stage. Thank you.
So thanks, Camille, and thanks, Mike. I hadn't been thinking about my SDSU days for a long period of time, but we did get into some interesting things. I think I got the first grant from the statewide initiative on HIV that came out of the University of California. We had a grant looking at that back in the early 80s, so go way back then for talk about complicated issues. So it's a real honor to be here tonight. I've known about this series, and I think what's exciting is, again, to have a community that's interested in this, and I'm really excited about this opportunity to engage the community, because we always talk about this a lot, but we often don't have the opportunities to do that and to hear from the community. So it's just terrific to do this. So I would echo what Mike said. Please don't be shy about what you put on those little cards, because we want that to help us in our discussions. So again, this is what I'll focus on, this Health Data Exploration Project. We were fortunate enough to get funding for this from the Robert Wood Johnson Foundation, and it's become a really fun project. It's really quite interesting. And this is one of several, but it's a unique project that we're working on in this area of personal health data. I want to acknowledge my collaborators on this, Matt Beets, who's an information scientist at UC Irvine and also part-time at UCSD, Cinnamon Bloss, who's a clinical psychologist, Joe Guadina, who's an epidemiologist who I recruited out of Cambridge to come work with our group, Beatrice, who's our assistant, Rashid Al-Khattab, who is a student assistant and super on our project, and Alex Ubenko. So again, we couldn't do things on this project without terrific support. So where does this come from? This comes from this expression that the Robert Wood Johnson Foundation, health happens where we live, learn, work, and play. It happens in our environments and in our settings. The traditional methods by which we have understood health, however, have been different from that. They have been randomized controlled trials where we set up a study and we collect data in a purposeful method, or biomarkers, the samples of blood that we draw and we assess this, electronic medical records, surveillance on a regular basis at a population level using surveys that are administered every 6 months, every year, maybe periodically going out into a community and capturing data. So that's the traditional method by which we've understood health. Well, things are changing. Things are changing enormously in terms of where we might get information about that health that is happening where we live, learn, work, and play. And I love this cover of The Economist, because it really does sum it up in terms of what that smartphone in your pocket is. By 2020, 80% of adults are going to have the equivalent of a supercomputer in their pocket. That's just an extraordinary development in terms of where things are going. Never offline, this notion of wearable technologies, wearable devices for tracking health states. I've got my Apple Watch on right now. It's tracking various things on me. And again, these are becoming increasingly ubiquitous. Social networks. I have to update this slide every quarter or two in terms of the number of people. Half of the people in the United States are on Facebook, using it on a daily basis. More are on Facebook, but this is daily users of Facebook. 1.55 billion worldwide. That's just stunning. Facebook did not exist as a company 12 years ago. This is, to go from that to this is just an amazing development. And then the Internet of Things, what Qualcomm is actually calling now the Internet of Everything. I mean, everything is getting an IP address, everything is getting connected in one way or another. And look at where we're going to be in 2020, 7.6 billion people on the planet, 50 billion connected devices. Sit back and think about that. That's just enormous. These connected devices are all leaving digital traces of our everyday lives. These are leaving lots of information, lots of breadcrumbs around in terms of what it is and where we go and what we do. And I think one of my overriding theses on this is that this is, and I think of the session tonight, this is for the good, but this is also potentially not for the good in the ways that we might discuss and know. But as a public health professional in my heart, I'm extraordinarily excited about the opportunities for the upside of this if we are able to manage and address this. So this increasingly diverse and expanding ecosystem of devices is generating lots and lots of data. Just, zettabytes of data, lots and lots of things from different sources. So this personal health data, what does this really mean for those of us who are interested in gaining insight on health? They can offer new paths for reflection and self-improvement on behaviors and lifestyles. You know, this tells me how active I was today, how active I was last week, did I do things more? It can help me better understand that. New connections with clinical care. I bumped into a couple folks tonight. Mitz Demita's here tonight, other people that I've worked with in the past, clinicians, and I've had another OBGYN doc here. And you know, we're really interested in applying some of these things in clinical settings and intervening and hopefully improving chronic disease, this crushing burden that we have with respect to the costs of chronic disease. So there's promise and potential in the use of these devices. And then new health knowledge from aggregate data. So in addition to the numerator data, to clinical data, population level data, public health data, what's happening in San Diego County, what's happening in the state of California, what's happening with women, what's happening with children. So this notion of advancing an understanding because of these new forms of data. So how can we use these data to improve health research and promote public good? We stood up this project to look at this. There are new models of inquiry, essentially new methodological questions that are raised related to the research that we might do. There are ethical issues, and I've had this slide for a while. Now we're talking about them tonight. How can we use these technologies to address disparities? We all know, and I'll comment on this in a few minutes, that the technology divide exists, that the haves and the have-nots. Even though technologies are pretty widespread, there's still main issues with respect to this. So can we use this to address health disparities, which is a very serious issue? And then costs. What are we spending per year now in this country with respect to healthcare costs? Want to take a guess? Somebody must know.
$4 trillion.
We're not up to 4 yet. We're going to be at 4 at about 2020, 2021, I think. We're actually going to be closer to 5. I think we just crossed the 3 trillion per year barrier. And that's, I think we're at 17, 18% of GDP. So this is extraordinary, way more than anybody else is spending, and we're not getting any better outcomes. So in our world, we say, when will health become, in the world of technology, when will health become better, faster, quicker, cheaper, rather than better, faster, more expensive? Important question. So we began this project in 2013, again with a small grant from Robert Wood Johnson. Our phase 1, we pulled together advisors to give us some direction in terms of where to go. People like Linda Avey, one of the co-founders of 23andMe, Hugo Campos, who's a patient advocate based in the Bay Area. He's the guy that hacked the Medtronic data because he was wearing a pacemaker and he wanted to access his own data from his pacemaker, and that was a classic thing. Bob Kaplan, some of you might know Bob. Bob was a San Diegan for decades, among other things, our department chair. He was then, at that time, head of the Office of Behavioral Social Science Research. Sendhil Mullainathan, a health economist at Harvard. Tim O'Reilly, a big champion of software, open software. Larry Smarr, who directs our institute. Martha Wofford, who at that time was at Aetna. And then Gary Wolf, co-founder of the Quantified Self movement. Anybody here a quantified selfer? Go to quantified self meetups? We might get into that a little bit. A huge movement. So what we did with our initial phase is we wanted to gather data. So we spent time talking to individuals, talking to researchers. What are they doing with these data? How might these data help what they're working on and to do? And we also put out a call and interviewed regular folk, people, what they thought about this. And then we did an environmental scan to understand what had been written in this area. And we identified a variety of issues, many of which I hope we'll be able to touch on tonight. Research methods, data quality, representativeness of the data, ownership in terms of use, privacy, ethics, cultural differences, et cetera. And I'll drill down a little bit into a few of these with my slides, and then hopefully we can talk about some of these. But again, this is wrapping our mind around this notion of something other than the traditional way that we do health-related research stirs up lots of dust, lots of things related to this. So to help us do this, we're building a network. We were funded after our first phase to build a network of researchers and innovators in this area, companies, researchers, and strategic partners. And we have, I think, 200 people in this network now, and we have about 30 companies and nonprofits and whatnot that are part of this. And I'd like to show this slide because you're nothing other than the people who you work with and who advise you. So we have, again, Gary Wolf has stayed on with this. Ernesto Ramirez, right there on the left-hand side, is a PhD student in our program here. And Julie Keenst up in the upper left corner is a computer scientist at the University of Washington. Jerry Sheehan is Chief Information Officer at Montana State. Patty Brennan is a nurse. She's a nurse engineer, chairs a department at the School of Engineering at the University of Wisconsin. Tanzim Chowdhury, computer scientist. John Brownstein, some of you might know John Brownstein, a computational epidemiologist, breakout things, health map and the flu trends and whatnot. John's a phenomenal researcher. Margaret McKenna, who is the Chief Data Officer for Runkeeper. Anybody here use the Runkeeper app on your phone? I see a couple hands. And then Patients Like Me is part of this as well. And then we have an attorney that's working with us, that's helping us think through some of the issues. So it's a really, and Eric Heckler at Arizona State, who's sort of a brilliant young mind in this area. So there are advisors, and we're doing certain core research areas, and I use this Venn diagram to describe how we've kind of mapped out the terrain. Representativeness of the data, methods and metrics for addressing it or using it, and then utility and safety. So we've had on the table issues related to utility and safety for a long time that include ethics and privacy. So take a moment and talk about representativeness. Technology adoption tends to be unevenly distributed. Different communities will have different patterns of use, access, et cetera, as I just mentioned, and then influenced by a variety of social, economic, and technical factors. And you know, we sometimes take for granted multicultural societies in California because we're surrounded by it, and many of us live here because we thrive and like these environments. But what that represents are people who look at things in very different ways, as we know. And so this is really pretty important. Anybody want to take a guess at what this might be? It's Los Angeles, but what am I depicting here on this picture in Los Angeles? If I told you this was tweets, but what else is different in this picture? Green tweets as opposed to orange tweets if you're colorblind. These are, yes?
They're all areas that are black.
Well, that's a good point. I wasn't going to make that point, but there's some areas that are black that might be parks or might be places where people don't tweet in their areas. But this is actually a map of people who are tweeting using Android phones and people who are tweeting using iPhones. Guess where the iPhones are, and guess where the Android phones are. iPhone's more expensive, Android's not. So, yeah, along the coast, expensive areas, and then what's in South Central LA. So this is again, you can go to any there are maps of cities all around the country that this person has put together. But this is a depiction of the digital divide in many respects, because Android phones are different than iPhones in terms of capability and whatnot. So it's quite interesting. So why does this matter? Generalizability. Again, we do research to be able to come up with meaningful knowledge from our particular research project that we can then generalize and use in other situations or other settings. So we want representativeness in our samples. We need to make inferences about what's going on. And then social justice, which is huge for me. In public health, the fundamentals of public health are epidemiology and social justice. And so this notion, we want to make sure that we have inclusiveness, that people are represented. And this is a terrific quote related to the notion of people remaining on the periphery of big data in many ways, or not being represented in the right way. So if we're going to solve problems, and the current problem, for example, the Zika virus, it's a perfect example of a problem that could break out in very unexpected ways, because we're not addressing and tending to the needs of the entire population, herd immunity, if we develop a vaccine, and a variety of things. So, again, very, very important. So what about validity and reliability? Now I'm going to shift gears, and I'm going to talk about another area that we're focusing on in our project. This is a table that we've developed. It's a little busy, a little noisy, but I thought you might be interested in looking at this because, again, on the left-hand side, traditional research data that I spoke about at the beginning, and then these new personal data. And think about each of the areas in the middle, the context of collection, the cost per observation. We are moving from very expensive, infrequently captured data to super cheap, continuous data. Major implications on that. Measurement trueness. We validate the things that we use in a clinical trial. We do things to assess and understand what's going on in a clinical trial. A lot of this is not necessarily validated. Specificity, comparability. So this is a way of thinking. And again, an audience like this, I knew you would probably appreciate this, because this is on the one hand this, and on the other hand that. And this is driving some of the way we're thinking about some of these things. So we're doing a study, actually Dr. Godina is doing a validity and reliability study, a scoping project in this. And this is to answer some of these questions. So these questions related, every week or two something comes up in the newspaper about the validity. Is Fitbit a joke, or is Fitbit better than other things? Is it not? Is it helping me? recently here, I think 3 state attorney generals sued Fitbit, the company Fitbit, because of questions, because somehow they were thinking that they were representing the Fitbit as being a medical grade device, and that somehow selling them in ways that the terms of use were somehow inappropriate. Potentially we could talk about something like this, but this is where, again, where we need to know. We need to know, do these devices measure things well, or do they not, especially if we're going to be drawing conclusions from them. So there are lots of challenges in this. Engineering specifications of these sensors are very difficult to find. There's often very proprietary issues. How they're used is proprietary. The algorithms that are used by companies are trade secrets, if you will, and not necessarily as open as some things that we might use in a research environment. The extent to which design and materials influence measurement is unknown. Lots of these are made outside of the United States, where quality control might be a little bit different than they might be here, or in entities or places that have less knowledge about them. And then the process of bringing these things to the new market. Just as soon as we validate one, then bingo, a new one shows up, and no universal criteria for judging. So we're swimming around in this right now. We've actually completed the review. I'll spare you the slides on this, but we've completed it. We're trying to assemble this now right now and put it together and post it to the community so that we know we can advance some knowledge in this area. So now, again, another pivot to privacy related issues, which we're also digging into as one of our areas. Lots of talk, obviously, the era of Snowden, other things. It's do we have privacy anymore? Do we not? What are the implications of this? Pretty important issue. And in fact, it's so important that we need to dig further into what it really means. And if you sort of scratch the surface on this a little bit, there's a lot of instability in the construct of privacy about what it means. And in fact, the thesis of some of the work that Cinema is beginning to work on is that probably if everybody in this room was asked what they thought privacy was, you would come up with a different description of it, a different mental model of it, a different meaning for you, a different meaning for your family, a different meaning for your children, potentially and others. And this I found really interesting. This is, again, I borrowed this from Dr. Bloss, but this notion, the whole construct of the right to be left alone, privacy, stems from 1890. Brandeis and Warren and a legal thing, legal determinations that they made at that time because of the rise of photography and newspapers. Before then, it was really just this right to enjoy your life and have your property and whatnot. But privacy, this notion of privacy, is a relatively recent construct. And I think if you think about that for a minute, and I think I will have an opportunity to talk about this, I'm not an expert in the aspects that relate to the recent constructs over hundreds of years and how we think about them as a society. But to me, this is a relatively new thing. So and it might be influenced by a lot of things that are just happening right now. Again, Hillary Clinton, it takes a village to raise a child. I mean, hundreds of years ago, long time ago, everybody knew what was going on in that town, in that community. Privacy didn't exist as we now think about it, behind a closed door or whatever. So concept in disarray, people don't know what it means, suffers an embarrassment of meanings, and this is really pretty important. Might privacy mean different things to different people, as I said? So this is a slide I also borrowed from her. Cinnamon actually asked her son, her mother, and her husband to draw what privacy meant to them. And her son was undergoing potty training, so you can see what is on the upper left here. Her mom lives with her. Privacy is a closed door, okay? I'm in my room now, and so lives with her and her husband. And her husband, who's an educator here in town, privacy terms, sort of a more formalistic thing. But this is the way people think about privacy. It's different. It's sort of interesting. So based upon this, also very exciting, and I think, again, I'd like to say that this came out of our project, I think it did, is this notion of if we don't know what privacy is, and we don't know how people think about it, but yet we are about the business of trying to improve people's understanding of it so that they can make appropriate decisions about things related to what information I might be willing to share and what I might not be willing to share, we have to be able to measure it. If you can't measure something, you can't manage it, you can't understand it. And believe it or not, there's not a good measure of how people think about privacy. So Cinnamon knocked it out of the ballpark on our first try, got an R01, a fairly major research project. to develop, conceptualize, measure, and understand individual privacy affinities, state, trait, those kinds of things. Do they change? How do they change? And doing this in a very grounded way with some super experts and both locally and elsewhere. So very exciting area. So we're also doing research, so-called Agile research projects. We've funded some people around the country to do research in this area. And these are small proof of concept projects, a little bit of money to get people to leverage their activity, usually their students in their laboratories and whatnot. And this I thought was the one that you would be interested in. This is when am I at my best? How might we think about using data from smartphones and from patterns of web use and whatnot to understand circadian rhythms. Circadian rhythms vary across time and across populations and whatnot. So how might we do this? And how might those then also relate to cognitive performance? Are people sharp and bright, or are they not? And what might we learn about this? So these are actually two people that are on our advisory board, Tanzim and Julie. So they're doing some pilot work on capturing the data, looking at interaction patterns, conducting a feasibility study, and then modeling some trends that might be predictive of what could occur. Each one of these Agile projects that I'm talking about, we are featuring on webinars on our Health Data Exploration Project website that's open to the public. You don't have to be a member of the network to see these. So I would encourage any of you that are really particularly interested in this to kind of Google us, find our website and see, because they'll be presenting on some of these results. Another one that I thought you would be interested in is this is a second project, and this is being done by Patients Like Me. Anybody familiar with Patients Like Me here? Do you know what that is? So I see a couple hands. So Patients Like Me is a group based in Boston, Cambridge, Massachusetts. It was founded by Jamie and Ben Haywood, who were two sons of a MIT professor, and they founded it because one of their another brother in the family had a chronic illness and was having a very hard time figuring out what to do with this particular chronic illness. And they thought, well, wait a minute, this is silly, and we're not getting enough information from the doctor. Can we find a way to share data and share information with other people who might have similar symptoms, maybe even the same condition and whatnot? So this also started in, I think, 2012, 2013. They now have, I think, close to 500,000, 600,000 people who go online to find patients like me. So they're sharing data, sharing information. And this particular project is focusing on people with MS. And the sharing, and I'm going to come back around and comment on this notion of sharing data because it's so important. If patients share data with other patients and share their experiences, often what can be rolled up is a better understanding of what's going on with that disease or that illness than any one patient might have, and dare I say any one physician might have, because these patients are rapidly going forward with a lot of knowledge, a lot of information, and hey, I used this drug or I didn't, or anybody tried this or whatever. And it's like we've all gone online and done now we want help on any technology. The first thing is they send you to the frequently asked questions page and the page where other people are doing it. And I've actually done that a couple times successfully, and it's really nice. So that's essentially that model. This isn't new. This actually started before the web. There were people sharing information on the internet through different groups on The Well. If anybody knows The Well, that was in the Bay Area. There was a group of cancer researchers supporting this for a long time. But Patients Like Me has actually ramped this up in some way, and in many ways rather, to strengthen the communication and capabilities. They're a business, so their business model is to aggregate some of these patients so that they can become research-ready subjects, so that people could be capable of being available for research. But this is a good example of a research project. Emil Chiuzzi is the research director there, a clinical psychologist, and was very interested in helping people with multiple sclerosis better understand their own illness, so self-manage their illness, and understand and titrate things like activity. Should they be more active? We all know that most people benefit from some level of physical activity greater than they're currently doing. I mean, very few people are doing as much as they should. But people with MS have limitations, and sometimes they can overdo, and then they get much, much sicker, much worse. So Emil was familiar with that. They were determining the status of people and then training them to essentially use these devices to self-calibrate and self-titrate. Pretty impressive work, and so I think this is potentially has the opportunity to go forward in a really nice project. And then another one, Keeping Pace, Dynamic Assessment and Environment Exercise. This is Rumi Trinara, who was who's doing work with Runkeeper data and actually looking at population level relationships. Runkeeper is a GPS tracker that tracks where you go and sort of intensity of exercise and whatnot. And so using this to get a better understanding of environments that might be conducive to activity or not. And now that I know that Dr. Kerr is going to be the next speaker in the series, Jacqueline Kerr, who's part of our group as well, has been taking this to the max in terms of using GPS to better understand and characterize where people go. And then finally, this towards privacy-aware research and development. This is another thing that we funded with the Center for Democracy and Technology in partnership with Fitbit to develop a set of guidelines and processes that support the use of these in ways that satisfy user preferences. So doing it in ways, somebody might be, hey, no problem, I'll use all my data. Other people might say, no, I want to be careful about that. And so how to do this. And this is taking a while to get done because of some, again, the legal issues that I mentioned with Fitbit, but progress is being made on this. So I wanted to comment on this initiative, this precision medicine initiative. Have folks heard about this? I see some nods. Yeah, this was, President Obama actually announced this in last year's State of the Union address. It was really exciting, and not this one that he did last month, but in the beginning of 2015, really putting his full faith and credit behind this initiative. It's actually Francis Collins, the director of the NIH, has been thinking about this for a long period of time, and it's this notion of really trying to move medicine from, on average, we think if you take this medicine for a period of time, you'll get better, to we know specifically that this medicine will work for you because of particular fingerprints that relate to you. And so this is launched. It's going to be $1 billion initiative over the next 5 years. More than that over the next 10, 15, 20 years. And I'm sure you've heard about the Framingham study, you've heard about the Nurses' Health study, the lipid research study. We had the Rancho Bernardo study that was here in San Diego, which was one of the great success stories of a big prospective study in which we understood a lot of things that we might not have understood. So this is going to be a prospective cohort with lots and lots of folks. And the intent is for this is to I actually co-chaired one of the committees on this. I co-chaired the mobile and data committee for this, and our recommendation on this was the kinds of devices and things that I'm talking about for this, and that's now happening. And so it'll be genetic data and drug data, but it will also be wearable and mobile data, and it will be environmental data, because all of these things relate to one another in terms of health and, frankly, in my opinion, medicine. So this is going to be pretty exciting. Those of us in the research side are always happy when there are more funds that are coming out related to research. So we write grants all the time. But importantly on this, I wanted to say a word about data donation, and maybe we can talk more about this in the question and answer. This initiative, the Precision Medicine Initiative, participants are going to be involved in the design so they can help create it. There's one of the 4 subcommittees. There was mobile data, there was electronic medical record, there was cohort engagement, and then there was essentially the methodological issues related to big trials. So this cohort engagement is all about putting patients in the center of this. Patients are going to be volunteers in this. They're not going to be conscripted. It's not going to happen to you without your knowledge. And ideally, flipping that, it will happen with you being willing to provide as much data as you possibly can about yourself, because that's what's going to provide insights on this. And Francis, again, the two big meetings that I went to in Washington and then went up at Intel, the big focus on this was, I'm happy to be a participant in the Precision Medicine Initiative. I'm really proud. I think this is a great thing to be a participant in, because I think I can help others by the knowledge that's going to be generated. And has anybody here participated in a clinical trial as a subject, not as a researcher? Don't see any. 2 or 3, it looks like, yeah. So people participate in clinical studies or clinical trials not for the money that you get to reimburse your travel. It's for altruistic reasons. It's because you care often about the problem, or there's meaning for you. Often somebody in the family might have had an issue or whatnot. So this notion of donating data is really important, and that's the way I state it. Donate your body to science now. Don't wait until you've died. We can learn a lot. We can learn a lot about you and a lot about populations if in fact we have your data now and we can track and follow. I have other projects that I'm working on that I can get into, but I'm doing a lot of environment exposure work and whatnot. But this is really critical, and the way I talk about it here in San Diego, at the Biocom meeting, for example, 1 million. What does that translate into in San Diego? How many of the 1 million? If we did it on a proportional basis, 10,000 to 10,000. We're 1% of the country, so we would be 10,000 of the 1 million in the cohort. And we're a terrific county because we're very diverse, economically, socioeconomically, ethnically. We have a variety of ages and whatnot. I call it the 1% example. I mean, we could be 1% of this. Imagine what we could learn. And not everybody has to participate in this to get to understand what's happening across populations. So I think this is my final slide, and then we can move to questions. Love this cartoon. I need to know how you're planning to use the data. I borrowed this quote at the top of this from Dave Ross, who's a colleague of mine. I actually got to know him when he was directing the public health informatics program at CDC 25 years ago. He now works with a big nonprofit organization in the greater Atlanta area. But the Data for Health project is another Robert Wood Johnson project in the broad space of these new forms of data for health and opening these data up in many ways. And I just love this quote: it will only move at the speed of trust. I mean, we can't get ahead of people's understanding of this. We can't get ahead of its availability. But if we can gain trust and if we can move forward with that, and there's a sense that there's a very solid quid pro quo, not only for individuals, but at a true public health population level, aggregating these data up and getting new insights will be profound. Half of premature morbidity and mortality in this country is unexplained. We do not know why somebody developed that brain tumor, why somebody got breast cancer when there was no breast cancer in the family, why that child got a tumor or whatever. We know some things, but if you actually look at the causes of death, 2.5 million per year, and you really run back and you get a sense of what, well, that person smoked like a chimney. Well, okay, that smoking caused that person's death, but why did this person who never smoked get lung cancer? Where did that come from? So that's what we stand to gain on this, is sort of the other half of the premature deaths that occur before, you know, nobody gets out of here alive, obviously. It's going to, you know, but we want that compression of mortality that Jim Fries talked about up at Stanford. And personally, I want to be about 95 years old, and Camille's a cyclist as well, and be riding my bicycle up Torrey Pines Hill as hard as I can and then have a heart attack. That will be heaven to me, because that's what I want to do. So that's it. Thank you for your attention on this, and hopefully we'll get some good discussion going on this in some way. Hopefully this is interdisciplinary.
So Kevin, thank you so much. That was just a wonderful presentation. So one of the things that you mentioned was your involvement in the Precision Medicine Initiative, and you were involved in the committees that President Obama initiated prior to his announcement or shortly thereafter. And I know privacy is a really big part of the initiative being successful. Do you know what kind of progress has been made on making sure that privacy is protected, since that's been such a key feature?
Yeah, this is a good question, and I remember I got this phone call. It was I think in December from somebody at NIH, and said, "Kevin, this is a big deal." So and it related to the Precision Medicine Initiative and came out of the White House. So on the privacy side, one of the people that was involved in the planning is Sharon Terry, and this is privacy involvement of folks and whatnot. Sharon Terry founded the Genetic Alliance, who's well known in the space that you and I think Mike and others travel in. From the get-go, I was there at the initial meeting, at the kickoff meeting, and was very keen on this notion of not getting ahead of people. As I mentioned, this notion of putting people at the center of this and ensuring that the rules of the road meet their expectations and don't go beyond them, and that any 10 people, some people are a little more open, other people might not be, that it be tailorable to the particular individual. This Genetic Alliance actually came, she had her own family issue with a particular illness or disease in a family member, and really knew it from her personal experience in her heart and her mind. And so I think that hopefully will be baked in with this initiative from the start, because I think you know, because this is such a high visibility thing, people do not want it to fail or collapse under the criticism that it's just people doing things to unwilling subjects or whatnot. So beyond that, I don't know how it will actually be done. Right now, the calls are out for the people who are effectively building the plumbing of this, the background, sort of the platforms and the methods. And I know there's a lot of discussion about the different people who are competing to be the person who does the plumbing for the medical record, the person who does the plumbing for the mobile data. There's competition now to find the right and best people around the country who can help people do that. I'm involved in a couple of those. So,
okay.
So with luck, it will happen well.
When is it due to start? When are they launching?
Well, right, again, it's getting up off the ground now. All of us are thinking that the 200 million, the plumbing is a relatively small amount. And again, I'm not speaking on behalf of the Precision Medicine Initiative. It's important that I mean, all I know now, they basically cut us loose from the committees, the planning was done, and then they took it back within NIH. So this is an important disclaimer. But it's tied to federal fiscal years, so 200 million will need to be spent this year, 200 million next year, and so we're all expecting RFAs. And anybody, I see a couple of people here who worked in universities, you know, that timing means we'll be hearing about this in the next few months and getting ready to do things.
Okay. So the term mobile health, or mHealth, has become part of the vernacular over the past couple of years. You were involved in a big workshop in 2013 that was basically saying we're going to be using wearable sensors, pervasive, you know, whether it be a contact lens or a sticker that you put on your skin. It's going to be measuring all different kinds of physiological, biological, social. So what has happened over the past 2 years that is making mobile health accessible to underserved populations?
That's a really good question, and I think part of what's happening is the focus of some of the research questions about some of the particular issues that are needed to be addressed by by people who are deploying these technologies so that they can be used in all populations. And so it's turning that into an empirical question about how do we actually get to the last mile? How do we get to people who might have particular problems with numeracy or literacy or certainly affordability of types of issues. We're pretty early in the game right now. We're pretty early in this process. But as I pointed out, if we're successful, we will have embedded the questions like that in the research agenda. And it will be entities like the NIH, the Robert Wood Johnson Foundation, the Centers for Disease Control, who will help push this forward. You know, I have a long history in this. I spent a couple of years in Washington, 1993 to 95. It was the early years of the Clinton administration, and I was working on technology policy. I'd gone there to work in this area of how we use interactive technologies to help consumers better understand their health. Okay, it's empowering people to better understand their health. Video discs, anybody remember interactive video discs? Yeah. Have any of them in your closet? Hang on to them because they'll probably go up in value. You can take them to Antiques Roadshow at some time. So I went there in 1993. When was Mosaic released? 1994. It changed everything, obviously. And I was working actually in the Office of the Assistant Secretary of Health in this area, and I will never forget presenting to the American Public Health Association leadership. They're based in Washington, D.C., so there's a room full of about 15 people on their board. And the concept digital divide didn't really exist at that time, but there was an article in the Washington Post at that time of where Atlantic Bell was going to be running the wires that would support internet access in Washington, D.C., and you could guess where they were going to run them and where they weren't going to run them. And I was pointing this out and saying, this is going to have profound implications for what we're talking about doing as far as reaching everybody. So I go back that far, working on some of the policy questions that relate to this. I mean, it's, you know, we will have poverty as long as we have poverty and we have inequality and whatnot, and I won't go there with respect to the current issues that are happening now, but I think, you know, we can't, one other thing I like to say is that, in my opinion, profound problems like this in public health have actually only been solved by improvements in technology. You know, think of clean water, clean air, sanitation, other things. I mean, in public health, moving from a time when there are lots of people who are sort of being damaged by things to where we're narrowing that down and reducing it, these have been technological solutions, and it's one reason that I get excited about this. I think we have a greater chance to target and improve these problems by the appropriate application of this. But we have to bring people in like Nadir. I can't see because of the lights, and he's there someplace, who are human-computer interaction and design people who can help us develop technologies that everybody can use. But my mother, before she passed away, she couldn't hold anything because of terrible arthritis and whatnot. Well, using a touch-tone phone was just not an option for her. So you develop a technology that works around that. So that's where I think I think the cup's half full in this area.
Yeah, because I think we live in a community that is incredibly diverse. And when I talk to people that are from the Latino community, the Native Hawaiian Pacific Islander community, these technologies that we're talking about every day in our daily work are not familiar at all to them. And yet they seem, in my opinion, to have the most to gain from having access to technology, especially access to technology that can help them monitor their health. So how do we bridge the gap between the people that are in the quantified self movement, who are high tech, high literacy, to those who are maybe lower literacy, not tech savvy, don't understand data? How do we bring them along so that they can understand how to use these different types of tools?
Yeah, good approach. And I'm going to come back again as somebody who believes in science and the power of asking and answering questions. We just completed a 1-year-long randomized controlled trial using text messaging, just simple text messages. Now, text messages are almost ubiquitous. I mean, any phone can accept a text message, and they're really commonly used. If you look at all the data related to it, low-income populations, others. We did a full intervention, English, full Spanish, over a year. Thousands of text messages populated into a computer, expert systems and whatnot in individuals for overweight, treating obesity and whatnot, and actually found a high level of acceptance across both populations, full English and full Spanish, native Spanish speaking people in San Diego County. And so, to me, when we publish that, when we put those results out, when we present that, that begins to move the ball a little bit further as far as what's happening. And I brought up the example of the web and whatnot. I'm of the opinion that there's no question that this is going to happen. The question is how well it will happen, whether we're going to do it in the right way, how messy it's going to be, and a variety of other things. But I think the imperative to provide many of these services to people of all types is really more a business imperative that Verizon and AT&T and Apple and Google and whatnot are doing.
So you had a really interesting slide about the Twitter data from Los Angeles. Can you tell us a little bit about what you've learned from using social media in your research and how we can actually leverage social media to predict health outcomes or predict potential outbreaks?
Yeah, interesting. And we've only dipped our toe into this. We just finished a 2-year study using social media, Facebook. It was actually the first study to use open Facebook postings and whatnot in the context of young adult weight-related issues. And so that paper's out under review right now. What we've learned is that everybody's connected. It's really quite interesting. If you think about trying to recruit people and keep them apart, in fact, they're connected in one way or another through their friends, so it changes the game as far as the research. I think the fact that again, social media now exists. It didn't exist. It's part of the zeitgeist. It's part of what we need to factor into where people get their information. They get it from their peers. They get it from their friends. Other things. So, keeping up with the Joneses, so to speak, on being able to use these methods for research is really key. I think we will see more and more of it. When I talked about this notion of population level surveillance and other issues, there's some very exciting stuff that's being done. People here at UCSD, at SDSU, John Ayers is doing some phenomenal stuff in that area. Others in their population science group. So, again, it's just I couldn't imagine not doing this now, because you have to go where the people are, and if the people are there, then you go with what they use and what they do.
It looks like, Mike, you have some questions. Just a few. Okay, just a few. Okay. Okay, let's see.
Can we read these?
Yeah, I have glasses on, fortunately. Let's see. How do you define healthy and not healthy?
Good question. And I don't know whether it's fair game here, but I know sometimes people come to sessions like this to hear and be heard. So if there's a way people want to clarify that might be bad form with this being filmed. But the question is, how do you define healthy and non-healthy? I tend to subscribe to the World Health Organization. It's sort of, a general state, and I'm going to mangle this, I think, but general state of health and well-being that is meaningful to individuals with respect to their own personal understanding of what is healthy for them. And often it's friends and family. It's being able to do what they do as a hobby. It's it's a variety of things. So it's less important what I think than to develop and work on these technologies to ensure that they support what people want to do and want to embody and express themselves. And that's why I say that this whole notion of consumer health technologies has been a passion for a long period of time, and it's self-defined.
It reminds me of a lecture that I saw that James Fowler delivered not too long ago about how he can predict obesity through the social networks that people have on Facebook. So I guess how you define health is basically what you're influenced by in your peer group.
Yeah, and I want to actually build on that in a minute. In part, as a public health person, a big part of defining health, to my mind, is there's a commonwealth. There is a health that at the community level that is broader and more. It's greater than the sum of the parts. And it's I'm involved in the Live Well initiative with our county health department, with some work that we're doing and whatnot. I mean, this notion of building a community, building a group. Dan Chavez is here with the San Diego Health Connect. I mean, this notion, health is partly an individual thing, it's a family thing, it's a neighborhood thing, it's a community thing, it's broader. And all of those levels are just extraordinarily important.
Okay, now we have a question on privacy. If privacy is not clearly defined, how can you protect it? In another word, if you don't know what they are, how can you protect it? So
QED. I mean, exactly. I mean, that's a good question. And if everybody says, I want my privacy protected, and then okay, game over. We're just not going to do anything. I think we all know what's happening to our privacy. I mean, I think it's this notion. You might get a speaker to talk. I'm not an expert on this, on de-identification. Can we truly, in the society of all those technologies that I read, that I covered, do we actually have the ability to be anonymous anymore? New York Times had an article last week, I didn't show the slide, 5 companies are going to dominate the digital future for the foreseeable future. Apple, Amazon, Google, Facebook, and Microsoft. And I gave a talk to a group of researchers last week in social psychology. How many of you in that audience did not use at least products from at least 2 of those companies daily for the last year? Nobody could raise their hand. I used products from 4 of those companies. And this notion, all of them are capturing data, all of them are looking at those data, all of them are using those data to address you, all of them know more about you than you might think they know about you because of the background stuff that they can combine with other things. So this is an enormous challenge, I think, for us. It's a policy question that we've got to address in terms of appropriate controls for the breaches of these things, like we see sometimes when there are breaches of credit card, or like what happened at UCLA when the medical records were breached and other things. But I think we are now at a time when re-identification is probably more likely than de-identification, and that's only going to grow. Again, I keep thinking about the importance of this for our understanding of the half of premature morbidity and mortality that we do not know. So that's important. Remember, why did that friend of yours get that disease out of the blue? So I think there's an upside here, but this session is really all about how we appropriately manage the potential downsides and get the speed of trust moving in an appropriate way.
So the speed of trust, I think, is a really fascinating component of this, and I'm looking at this from people that are doing research using research-grade tools, and now combining studies that are using commercial-grade tools, like a Fitbit or an app that you can download. And we run into the guarantees that we could offer participants in research studies for some protection of data. And now when we introduce commercial products as research tools, we are now bound by these terms of use that most people don't read, and if they ever read them, they probably don't understand them. But even if we have terms of use, those have not been regulated by the FTC, and that's just now getting to a point of being managed to some extent, right?
Absolutely, yeah. And an important thing on that, even if the terms of use are crystal clear and can be written on a 3x5 card, the companies that are capturing these data basically own the data. You might think that you own the data. When we did this, a lot of people think that when you're doing this, that, well, that's my data, I own this, or whatever. No, almost every term of use is an asymmetric relationship between the company that's getting the data and you. And you know, if you're getting things at very low cost or free, you know, you're the product, not what you're using. They're using the data from you to do something else. And so this is really important. It can be trumped, though, by, and I hate to use that word, but it can be handled. You have the ability to donate your data. You know, the blue button, people know what blue button is? That was a thing passed a few years ago. You can actually, they wanted, why isn't there a blue button I could push that would allow me to bring out all of my medical record data out of my record and just have it? So that was actually mandated, so that's there, and technically you can do this. Now, easier said than done, but there are approaches to this. But that's actually what we're hoping for in the precision medicine industry. That was sort of said a super blue button. It's sort of like the way to get around HIPAA and whatnot for these volunteers is volunteer all your data. Or maybe you can be a participant and you can volunteer 90% of your data. You do not want the visits that you did to a mental health professional released, because the sensitive issues you discussed with a psychologist you do not want to be, and I'm not talking about your name attached. This will be largely anonymous data sets, things where it will just say male, female, age categories and whatnot. But when I commented on this notion of re-identification, in reality, re-identification is actually quite, becoming increasingly easy to do if you know enough things about a particular thing. There's only 3 white males who live in that zip code who buy ice cream once a week, who drive a Toyota with over 50,000 miles. All those things can be learned about you. So donating, on the other hand, if you're comfortable donating, then it's a moot question. Like, it's okay. I always tell people, I don't mind telling people that I have most of the medical problems of a man my age. I mean, we were at a meeting, we were throwing up stuff, and this is the prescription that I got for this particular thing or whatnot. I can't change who I am and what I am. That's it. But there are probably some things that I wouldn't want to share, and so I would be along that continuum in some way. So I've said enough of that.
But it sounds like you'd like control. If you'd share, you'd like control. Yeah,
good point, yes, yeah. And that's actually a very good point. This notion we have found, and I think we will find more in the work that Cinnamon is doing, and that we actually found this with some other people we interviewed, is that privacy preferences and sharing preferences vary over time. So, you may be more willing now to share, but something might happen and you wouldn't want to share, or you wouldn't want to share some new things. So this notion of concurrent and successive ability to do it in ways that work for whoever you're sharing it with, but that also keep you in some way in the driver's seat, and again, don't get ahead of you. That's really a kind of I think a potentially critical issue.
Yeah, so I'm thinking that control and transparency are really important aspects to this. So the terms of use are not transparent, and for some reason the public trusts the I agree. And you can download 93 pages and try to get through it.
Yeah, but I want to use the app.
But you want to use the app, right? So somehow we're putting a lot of trust into these products that have no rules for guiding how they're developed. So I think that's something that we need to be cautious about. Here's a question. How do you see mandatory, oh gosh, I'm sorry, I can't read this, by insurance companies in the future about data they will require for their products?
Mandatory?
Yes. How do you see mandatory by insurance companies? That's what I'm getting at.
Anybody want to shout out what that word is, if it's your question?
Yeah, it was from a financial services perspective, when you look at insurance products, how will they use this technology to mandate the types of data going forward to either give you access or deny you access to their products?
Yeah, that's a good question, and I think we're going to chip away at that a little bit as a society. I think that part of that, what we found with the Affordable Care Act, for example, it is now no longer acceptable to deny people coverage based upon pre-existing conditions and whatnot. So I think my sense is, as a society, as we move forward, if we move along the path that we typically have with, again, public health related things where we know what's good for individuals and for the public's health, is that those things will be increasingly put in smaller and smaller boxes. We will have fewer and fewer of those things where there's a parsing and for better word, lack of a better word, discrimination against people because of certain things. So I think there's my sense is that I'm hopeful that we will come up with regulatory approaches that will allow us to avoid much of the discrimination that might occur, as did happen with that. Now there's the Genie Act. I mean, there are different things related. There still are some big things that have yet to be solved. I'm not an expert in those areas. There are other people who can talk much more appropriate. But I think the path of history has been to identify those things and then address them head on.
So a lot of this is, again, getting at control. I think people are, from what I've learned, they're comfortable having control about what they share, but they don't want somebody to take their data without their permission. So this question is, how can an individual control the data that they generate? The next part would be, and how do they control how they share it? Yeah,
and good question, and we don't have the answer to that yet right now. There are different models that are being proposed. There are some people who are developing approaches that allow people to monetize, to actually sell their data. You know, my personal data, if I donate it, I'd actually like to know when it's used, and I want to generate, if somebody's making money off my data, I want a little piece of that, kind of like a royalty. You know, like you get something, you get a royalty. So there's a line of work. There's a local company here, Portable Genomics. I think I've got it right. It's he's attended a couple of our meetings where it's an app and you can get your data, and he wants to sell these data to pharmaceutical companies, and in turn you would then get some return on that. On the other hand, there is a sense, we've commissioned a paper actually on data ownership. It'll be coming out, we hope. It's taking a while because this is such a hot area. The legal scholar that we asked to write this paper is just being pulled into all these meetings in Washington and whatnot on data ownership. But she came to our meeting last year, you know, Barbara Evans, and I just loved this concept that these personal data that I'm talking about are a natural resource. They're like water or air or whatnot, and should anybody own these data? Or do we, especially from a collective perspective, do we own these, especially if we know we can benefit from these in ways that can be done such that they do not harm an individual who produces the data, then that natural resource, understanding what's going on across the population, benefits us all. And so that's a very important, I mean, this notion of a precious natural resource. We protect our natural resources. We have laws that protect air quality. We have laws that protect water quality. They're under assault from time to time, and they can go back and forth, but this notion, it wasn't an issue 10 years ago when you couldn't look at these data. All you could do is ask people questions. Did you sleep last night very well? Now we know whether you slept. And if we know, maybe we can get a better understanding of you, people like you, and in future generations, your children, your children's children, about what we might do to improve and optimize these things. So it's a stunning development, I think, and that's why this conference tonight and these discussions are critical to be. We all need to be as informed as we can be, I think. But I'm preaching to converted here. You're here tonight because you want to be informed. So,
so speaking of informed consent, there's informed consent to seek treatment. So most people that are seeking treatment, they're a patient. That informed consent is not an informed consent like we think about it in research, where if you're seeking treatment, if you don't sign that informed consent, you're not going to get treatment. Right. So if you're a research participant, it's really supposed to be voluntary. And the model has been to give people a stack of paper that is really dense with words, complicated terms that are reviewed and approved and seen as acceptable for, you know, seeking volunteers for research. Now that we have these new technologies, we have these new methods, new tools, do you have any visions about how informed consent might look moving forward so that it actually results in a meaningful, informed person, kind of bringing the public along the path?
Yeah, good question. And of course, you're emerging as an expert in this area, so your new project is going to focus on this. I think it gets back to this notion about not getting ahead of folks. I think in some situations, we will not get the kind of informed consent that we would have gotten in a randomized clinical trial where we know we're going to follow people for a year and we can assure them that at the end of the study their data will be destroyed and nobody will ever see it again. That's going away, those kinds of things. So we have to find ways to assure, and it's always an active assurance and a passive assurance. You know, as a physician, you know, my whole life has been, you know, you do no harm, act as an agent on the best interests of your patient. As a public health person, act in the best interests of the population or the community that you're serving. And you don't always have the luxury of asking people. You can't go around the community asking everybody, is it okay if we do this or whatever. That's why we have representatives, we have, you know, laws and regulations and other things. So I think it'll be a melange of things. It'll be a variety of things that with appropriate oversight and checks and balances will allow us to move forward. I know one thing, I don't want to leave all this in the hands of Apple, Amazon, Google, Facebook, and Microsoft. They're terrific companies, I think, and they're rivals to us now as far as research. They hire our best students. I lost my best data visualization guy to Facebook first to last month. And these people, I will tell you, these young researchers that are joining these labs are as passionate about research as I was when I went into it and started to do. I was a clinician and administrator, but then I got really excited about these things. So if we can find a way to leverage that, but you know, we regulate some companies. San Diego Gas and Electric is a utility. Apple isn't. That's a policy issue. Some things that they do are regulated. And I'm giving a talk in Germany. I mean, I'm looking, we do things in this country, they do things in other countries in different ways based upon their history. This again comes back to an informed citizenry, informed policymakers who do the right thing. And what's happened recently with the communications, the FCC is keeping an open internet. I mean, if any of you are following what's happening with that, this notion of openness and whatnot, so it's a level playing field for everybody to get on. There were lots of people who didn't want to see that because many companies said, no, we want to control part of this because there's a lot of money to make. I mean, if you think that these things don't make a difference, I beg to differ, and so that's why it's important to understand and to speak up and to, you know, attend meetings and other things to do this. All of these things are going to be dealt with now. What was the common rule? Is it still open for comment now?
No, it's not open for comment anymore,
okay.
But they haven't released the final common rule.
Yeah, so this was all the stuff related to how we actually create an infrastructure that supports and governs informed consent.
Right.
And all of this comes, you know, where does informed consent come from? Anybody here know? And Mike, you can't answer this question, wherever Mike is. Where does? Belmont Report, okay, but what predated that? That was, actually Tuskegee wasn't on the radar screen at that time, if I'm not mistaken. Nuremberg. Yes. The Nazi experiments. At least that's my understanding. I'll let the real experts. But the horrific things that were done under the auspices of science to do things. So Nuremberg, and then it came, and the Belmont Report was the landmark report that then fed into, and now we have the common rule and whatnot. I mean, talk about things that are not that long. I mean, we have people in living memory now who remember those things. So this is still in development, and still, this was open for comment. 600 pages or something like this. It was this incredible document.
It's around 500. In case you had trouble sleeping.
So that we will be promulgating new rules, and Camille can talk about a really exciting project that she has that's related to this. But I don't know.
Well, this is the first time. How many of you are familiar with the Common Rule? These are the rules that govern human research protections, and the only organizations that are required to abide by it are institutions that accept federal funding to do research. So how many of you out here remember the Facebook study from last summer of actually 2014, when they manipulated the feeds of their consumers? And then they published a paper. Jeff Hancock and another guy published a paper about what Facebook learned by manipulating the feeds of their 800 plus users. This was 800,000 users in the sample. Now, they would have been doing this research regardless.
They do it all the time.
They do it all the time, but the academic wanted to publish it. So then it became public knowledge, and the public was outraged. How many of you are familiar with this one? Okay, so you remember this. So Facebook doesn't have to follow the common rule. They don't have any rules to guide how they do research. But because of that study, they are now creating an ethical review system, just now, because they don't want to upset the public, which is their consumer. So it's interesting how slow these things are to catch up with what we've been doing for so long.
Yeah, in fact, I'm involved in an initiative. We're releasing the report, the final report. It's been out for open comment for the last few months on self-governance guidelines in this area. So I've worked with the Vitality Institute in New York, and then also the Microsoft. We published a paper on this notion of guidelines for self-governance of the use of personal health data and personal health technologies. So there will be some guidelines out there. If a company wants to be a self-governing company that's sort of, hey, we're good guys, we're at least being transparent about what we're doing with this, we will adhere to or follow some of these guidelines. That's another method by which sometimes this happens. But again, America has, a history. Any capitalist country has a history of essentially allowing companies like this to do what they do and in an unfettered way. And of course, we've all seen the ebb and flow back and forth about many areas in this. But anybody, the book The Jungle? The food industry was completely and totally unregulated until, who was the author of The Jungle? I'm blanking. Upton Sinclair, yeah. Horrific things related to, and that led to, I think, the FDA, if I'm not mistaken, and other things. So we're maybe we're in the Jungle 2.0 right now with these things that are going on, and I hadn't thought about that before. I'm gonna have to remember that.
So this question gets into, so we've been talking about health data, personal health data that's collected by all of these different devices and wearables or apps and things that we carry with us. And this one takes us a little bit back to how can we possibly safeguard genetic data? And if I donate my genetic interests, my genetic material to a study, how can it possibly be sufficiently de-identified when database exists of people's genetic data with last names or ethnic heritage?
Yeah, and again, I'm not an expert on genetic data or de-identifying, but my general understanding of this is that is diminishing in terms of the assurances that it will remain de-identified. That's what I talked about, and especially with these other forms of data. So I think we're getting into a situation where, in all likelihood, we're going to have to keep up with the regulatory and or professional practice standards, the ethical guidelines and whatnot, that check and balance the misuse of those forms of data for, again, purposes that would go against the common good or go against any particular person's ability to live their life the way they wanted to, or their children. I mean, the HeLa, there are lots of examples related to this. So I'm really not an expert on this, so I really don't know, so I'm going to shut up.
So what I understand is that with just a very little bit of genetic data, inferences can be made about who the person is, and there's new tools and techniques now that you can be fairly confident you can identify somebody. So this is all the genetic data, but I think we have a lot that we can learn from the genetic decade of trial and error and best practices that have been developed in GINA. As we move forward, I think we can adopt a lot of what they've done to start applying that to this different kind of personal health data that's being collected.
Yeah, I certainly hope we can pull that off. Because I didn't show it, I use a diagram where I talk about, or a figure, where I talk about the influences on health, and it's sort of like a layer cake, and it's the environment, genetic data, microbiome. I don't know if you've had anybody come and talk to this group on microbiome, medical issues, behavioral, and then social and public health. All of these things in this layer cake continuously interact with one another, just in a systems way over time. And many of them are highly identified, where you live, where you work, whatever specific things. But many cut across entire populations. So every one of these layers is increasingly becoming digitized in very important ways and combinable in very, very important ways. So what Camille said is right. We're going to have to find ways to be comfortable in this big data world that we're in.
So do I really have to know if and when I'm exercising how many steps I'm taking every day?
It helps. So
So tell us a little bit about citizen science and how that helps, how monitoring and self-monitoring can make us...
Yeah, I was just going to say, it might not help you, but it might help your spouse. Help you, okay? So if they know how active you are, because that's your spouse, or some family member might be an influencer on you in one way or another. Really good, I just had a thesis defense today on this question. I mean, the notion of how people begin to understand this. We are moving from a situation in which we might not have known those things to where we are more knowing. Evidence suggests that if a physician gives a patient a pedometer and says, I think you need to walk more because you've got an issue with your health, that person will walk 3,000 more steps per day, 6 months to a year out. I mean, we know that these things help. We know that walking improves health. We know that the more activity you do, the better. Some is better than none, more is better than some. Fair amount is even better than that for fitness and health, especially for a variety of things. So the concept of having ubiquitous technologies that allow us to understand how much energy we expend during any given day by steps or whatever. And increasingly these technologies are also being used to understand how often we sit in our duffs, sedentary behavior, and how well we sleep. Sleep is incredibly important. And in any given day, what's the balance between sitting and walking for you that made you sleep best that night? Mm-hmm. On average. If you know that, on average, and you're having a problem sleeping, it might help you improve your sleep, because you know if you sleep better, you're going to be doing better with your family and at work and whatever. So all of these things moving forward, this notion of better understanding of what's going on with folks can help. And the citizen science, it's actually worth the talk in and of itself. People who are willing to sort of jump in and do things themselves, crowdsourced science, and helping others by just what they do. The weather nut that contributes the information on weather in their neighborhood, but we're now citizen science on steroids. Everybody's got a mobile phone, they can take a video, the mobile phone has dozens of sensors in it, it's got all this information that can be brought forward to help folks. It's tapping, it's kind of like the Uberization. There's a huge untapped intellect out there that can be brought to bear on problems. It isn't just in the ivory tower in which we sit.
Right.
And we're just, we happen to be there because of dint of luck and a variety of other things. So it's I think it's a game changer potentially, but we're at a very early age of this right now.
Yeah, I was just reading a paper about I can't remember the name of it. It's the eye, where they're outsourcing, it's a gamification to map the neural network of the eye. And they've just published a paper on it recently, and they cited, I need to look this up because it relates to my class for tomorrow, but they cited all the citizens that participated in the study.
Yeah.
And it
it's
was
like
just
the credits at the end of a movie. All these people that did this. Did anybody know we have one of the real experts in citizen science, not in health per se, in San Diego, UCSD, Albert Lin. Albert Lin would be a fun person to come. I'm not sure that there are ethical issues related to this, so maybe if you get an opportunity to hear him. He is the guy who found Genghis Khan's tomb in Mongolia. Nobody knew where it was, but he's an expert in so-called remote sensing. These are these high-resolution satellite images that are taken. Oil companies use them for exploration and whatnot, but you do these super high-resolution images that can get down to find that cup on this table, but it's a satellite. And he crowdsourced this millions of pictures of Mongolia to lots and lots of people and said, try and find a perturbation in here that might be man-made. Because I think Mongolia is actually bigger than the United States in land. It's huge, and it's largely unpopulated. It's very, very big. And nobody ever goes in lots of places. So long story short, they found him. He's a National Geographic special. You can Google it and you can find the National Geographic special. Him riding in on his horse. He's this young guy, a PhD in materials engineering, riding in and finding Genghis Khan's tomb. And a phenomenal story. But he couldn't have done that without, again, thousands of people looking at images. No one person could look at all those images. And the thing that was being looked for wasn't something you could train a computer to do, as well as this computer up here. Yeah, so it's just a fascinating story. Really worth checking out. He's one of our rock stars in Cal IT too. He's just an amazing guy.
That's an amazing place, Cal IT too.
Yeah.
It's really amazing. So I think we have time for maybe one more question. So I've got this question here. How have studies like 23andMe and the National Geographic DNA studies used these methods? Okay.
Well, 23andMe did start. It started as a company to essentially do what I talked about with patients like me, and that is aggregate lots of data across lots of individuals who would be willing to give information on their genetic, give a swab from their throat essentially and send it on. I did it. I did it because James Fowler sent a note around before Christmas a few years ago and said, "There's a sale at 23andMe," and I was shopping on Amazon for things for and a sale on 23andMe, and so sort of, okay, I'll click the button and for $199. It's less than that now, but they aggregate these data across lots and lots of people, and it's a good story. This notion of what you can learn aggregated across many people who then give you additional information is more than you can learn in any specific study where you're trying to enroll this person or that group. It's not necessarily better for everything, but it rolls up lots of data. And now 23andMe is, of course, selling some of this to their business model is to be pharmaceutical companies and others can use these data to better understand what might be happening. And they got into a little bit of hot water, as you know, by virtue of telling people more than they should have, genetic counseling based upon what they're getting, because they're not set up to do that, so they had to back off. I think it was the FTC that jumped at them. But actually, the founder of the company is Ann Wojcicki. It was the former wife of Sergey Brin. She was at the first precision medicine meeting. So if you look at that picture of those of us in the room, and the only time I've ever been in a meeting with her, but very impressive, and the comment she was making on this. And of course, Linda Avey was an advisor as well. So how can these be used? Well and hopefully productively, and not in ways that go against our interests as a nation and as an individual or society.
Well, thank you so much, Kevin. This has just been incredibly insightful and
thank you. Thank you.
I want to go further and thank both Kevin and Camille. You two have really helped give us a very rich picture of these issues. I want to thank all of you for your participation, and I also really do sincerely want to hear from you on the evaluation forums, what you like, what you don't like, what we can do to make these programs more effective. We look forward to seeing you at future programs. Thank you very much.